Bismillah ar-Rahman ar-Rahim. As you can see, the topic of today's lecture is going to be on diagnosis and management of periodontal abscesses. Now, in this lecture, we will be studying what is periodontal abscess, how do we classify abscesses in general, how do we identify these abscesses in the dental clinic, and how do we manage or treat the periodontal abscesses. Starting off with the definition of periodontal abscess. Periodontal abscess is a localized purulent inflammation of the periodontal tissues. It is a common dental emergency, often resulting from the rapid destruction of periodontal tissues. Definitely, the formation of periodontal abscess negatively affects the prognosis of the tooth and has a very important role in the tooth loss. So therefore, it is the most common dental emergency we find out and identify at the dental clinics. We need to know how to identify it, classify it, and also treat the periodontal abscesses. Coming on to the classification of abscesses in general. Periodontal abscess can primarily be classified according to the etiology, its location, its cause, whether it's acute or chronic, or according to the site. Is it occurring in a single site, recurrently occurring in a single site, or it is present in multiple sites of the oral cavity? Let's start off by the classification of periodontal abscess or the identification of periodontal abscess by its etiology. Now, we have been teaching you that dental biofilm is the primary etiological factor which initiates and aggresses any type of gingival or periodontal disease conditions. So similarly, the initiation and formation of periodontal abscesses also starts with the persistence of microbial plaque in a periodontitis patient with an already pre-existing periodontal pocket. Okay. Next etiological factor would be the acute exacerbation of untreated microbial plaque associated periodontitis. So what do we mean by that? You know that periodontitis occurs in periods. There are periods of disease activity followed by the periods of disease inactivity. For example, we have a patient who has a persistent periodontal pocket over a period of time when this periodontal destruction becomes chronic and the disease activity switch from inactivity to activity, then there could be the acute exacerbation of untreated plaque-associated periodontitis. The third etiological factor for the development of periodontal abscesses would be periodontitis non-responsive to therapy. What do we mean by that? We identify that the patient has periodontal pocket. We go ahead to treat it. We do non-surgical periodontal therapy. We give oral hygiene instructions to the patient. We put the patient on a maintenance phase of 4 to 6 weeks. We recall the patient. We see that there is persistent periodontal destruction and periodontal abscess or periodontal pocket formation. We go ahead with surgical phase after the maintenance of the surgical phase or before itself. We can see there is formation of periodontal abscess. If periodontitis is non-responsive to therapy, No wonder whether you do a non-surgical therapy or you give systemic antibiotics or you give you do a surgical therapy, the periodontitis, the periodontal destruction is non-responsive to whatever treatment you're doing. That means there is persistence of periodontal destruction. There is persistence of periodontal pocket. The third and the last is the same thing during supportive periodontal therapy. In all these conditions, there could be the initiation and formation of periodontal abscesses. So the primary etiological factor which initiates and aggresses periodontal abscess is dental biofilm present in periodontitis patients who have pre-existing periodontal pocket. Remember, periodontal abscess means there is periodontitis, there is persistence of dental biofilm. Next, coming to identification or classification of periodontal abscesses based on its location. Now we know that there are around 4 different abscesses in general we can see in the patient while we are diagnosing the patient. The first being the periapical abscess. So this is how periapical abscess looks like. Now the primary etiological factor which causes a periapical pathology is of course the extension of dental caries from the enamel dental pulp. There is pulpal necrosis, there is periapical pathology, there is periapical apical periodontitis, there could be sinus tract formation, there could be periodontal or periapical abscess. Okay, so this is how a periapical abscess looks like. Then we have something called as gingival abscess. Now, a key to remember the clinical features of gingival abscess and periodontal abscess is similar to the gingivitis and periodontitis. Gingival abscess means that the abscess is confined to the gingiva. There is no periodontal destruction seen in a patient who has gingival abscess. So now the next question arises is what actually causes this gingival abscess? Gingival abscess occurs due to the presence of foreign body between the gingiva and the gum. Now the example, a simple example would be sudden biting on an apple core or faulty tooth brushing technique where sometimes we come across when we are in a hurry, the bristles of the brush, it impinges into the gingiva, deep in the gingiva, forcing the debris to impinge into the gingival tissues, leading to the formation of gingival abscess. So this is how gingival abscess looks like, which is more confined to the gingiva and slightly the interdental papilla. Now if you can see the periodontal abscess in a patient who has periodontal abscess, I told you definitely there is periodontal destruction. There is a pre-existing periodontal pocket. Okay, so this is how you detect or you identify periodontal abscess. Okay, the last abscess is the pericoronal abscess. You know pericoronitis, so this is pericoronal abscess. Usually occurs due to accumulation of bacteria below the operculum of a partially impacted or partially erupted last molar or third molar. Okay, so I hope you can now differentiate between periapical abscess, gingival abscess, periodontal abscess and pericoronal abscess. Next, okay, this is another example of the same gingival abscess. The creamer looks like this: periodontal abscess and pericoronal abscess. Next, coming to the acute abscess and chronic abscess. Identification of periodontal abscesses based on its course, duration, and onset. So, periodontal abscess can be broadly classified into acute abscess and chronic abscess. Acute abscess, the term itself tells us that it is mild to severe discomfort or pain. There is a localized red ovoid swelling. There is persistence of periodontal pocket. There is pre-existing periodontal pocket which triggers the formation of periodontal abscess. There could be tooth mobility due to the extensive periodontal destruction. The tooth could be slightly elevated from the socket. Definitely the patient will have pain and tenderness on percussion or while he or she is biting on any objects. There will be exudation, there will be fever or elevated temperature, there will be lymphadenopathy. All these are the clinical features of acute periodontal abscess. Now let's see what are the clinical features of chronic periodontal abscess. Okay, in chronic periodontal abscess, of course, the term chronic means the disease is occurred for a prolonged period of time, and hence you cannot recognize the cardinal signs as much as you can recognize in the acute phase of any disease for that matter. So if these periodontal abscess becomes chronic, there will be no pain or very dull pain the patient experiences. The same thing, the patient will have a localized inflammatory lesion, slight elevation of the tooth, intermittent exudation. There could be sinus tract formation of fistula without any systemic involvement, means there is no fever, there is no lymphadenopathy. Okay, these are the very important points to differentiate between acute periodontal abscess with chronic periodontal abscesses. So this slide is very, very important for you to know. Coming to the diagnosis of periodontal abscess, what are the diagnostic tests or the diagnostic tools which help us to identify and to differentiate the different types of periodontal abscesses? One is palpation. Is the swelling hard or soft? Is it fluctuant? Second is percussion. Is the tooth tender on percussion or it is non-tender on percussion? Is there pain or is there no pain? Is the tooth vital or not? In case of periapical abscess, of course, many a times the tooth is non-vital because of the necrosis of the dental pulp. Radiographically, how do we detect abscesses? It is detected as a radiolucent area. Of course, here we have it in between the furcation area. It could be anywhere along the periodontal pocket. Okay, this is a diagrammic representation of gingival abscess occurring confined to gingiva, periodontal abscess, gingiva, and the underlying periodontal tissues. Apical abscess, of course, towards the apical surface of the tooth. Okay, then this is how you detect gingival abscess. Clinical features of gingival abscess. Gingival abscess, again, like any other abscess, is a localized inflammatory lesion that arises from a variety of sources, as I told you before. It could be plaque, it could be trauma, or it could be foreign body impaction. Okay, it could be due to improper brushing technique, where the bristles of the brush would impinge on deep into the gingiva, causing the formation of periodontal abscess, a gingival abscess. I'm sorry. Clinical features, how do we detect a gingival abscess? Is again abscess. Any abscess is of course detected as a red, smooth, shiny, painful, fluctuant swelling. But how is gingival abscess different than periodontal abscesses? That in gingival abscess there is no periodontal destruction. There is no periodontal pocket formation. There is no attachment loss. The abscess is confined to the gingiva. So by now we know what is an abscess, how do we classify periodontal abscess, how do we identify periodontal abscess based on its etiology, its onset, its duration, whether it's occurring in single site or it's occurring in multiple sites, how do we differentiate between acute abscess, chronic abscess, what are the clinical features of acute periodontal abscess, what are the clinical features of chronic periodontal abscess, how do we differentiate between acute and chronic, what are the clinical features of gingival abscess, what are the clinical features of pericoronal abscess. Now, after knowing this, let's move ahead for the management of acute periodontal abscess. Now, the main goal for us while we detect the abscess is to resolve the acute lesion immediately and to manage the resulting chronic condition. For example, we find a patient with acute periodontal abscess. Our goal for the management of this abscess is immediate treatment, incision and drainage, and then put the patient on maintenance phase and check whether this acute phase becomes chronic, and then it could again reoccur as an acute exacerbation of the chronic condition. So we need to treat the acute lesion and we need to monitor the patient for the resulting chronic condition which the patient could have. This is the main goal for the treatment of periodontal abscess. Now, if you would remember, I told you the primary etiological factor is dental biofilm. So it would be definitely incision and drainage first, followed by scaling and root planing. If you choose only to do the incision and drainage or drain the periodontal abscess through the pocket with the help of the periodontal probe by applying digital pressure and fail to do a good scaling and root planing, there are high chances that the periodontal abscess will reoccur. So the main criteria for management of acute or chronic periodontal abscess is first drainage, followed by scaling and root planing on the same visit. After you do this, you advise the patient to use salt water, gargle with warm salt water for next 24 hours, and then you call the patient back to check after 2 or 3 days. Now, if there is no access to the drainage of the periodontal abscess through the pocket orifice, then of course we need to have a surgery, periodontal surgery, which involves the incision, sometimes also flap reflection, to drain the abscess, to do a thorough scaling and root planing in order to treat the periodontal abscesses. Okay, we will be studying in which circumstances systemic antibiotics becomes mandatory. And of course, when you come across that the tooth is, the prognosis of the tooth is very poor, we cannot save the tooth, then of course the only option remaining is extraction of the tooth. Okay. Next, coming to the management of acute periodontal abscess, the same thing as I told you before, it works in managing the acute, resolving the acute phase of the lesion and managing the resultant chronic condition. Okay. Now, before treatment, you have to take a thorough medical history, dental history, the systemic conditions before you determine the possible immediate need of systemic antibiotics. This is a very, very important point you need to understand. When the patient is telling you the patient has diabetes mellitus, of course, there are high chances that the patient will have multiple periodontal abscesses, which cannot be treated only by doing this incision and maybe it requires systemic antibiotics. Okay, so therefore it is very, very important for us to take a proper medical history and also the current systemic condition of the patient. Is there any systemic signs? Is there fever? Is there lymphadenopathy? Is the patient diabetic? Does the patient have any autoimmune disease, etc.? So in which patients you prescribe antibiotic therapy for acute abscesses. In case of all these conditions, if you have a deep inaccessible pocket, if the patient has systemic involvement in like fever, lymphadenopathy, immunocompromised patients, inaccessible pocket where you're sure that you have left behind, you're not sure that you have done complete scaling, you maybe have left behind some calculus and plaque in the periodontal pocket, which may aggravate again the reoccurrence of periodontal abscess. In all these conditions, of course, also you have to give antibiotics. The standard antibiotic which is prescribed for all periodontal infections is of course amoxicillin. Okay, this is the loading dose. 1 gram is a loading dose followed by the 500 mg of amoxicillin 3 times a day for 3 days. Again, reevaluation to determine the need of adjustment or continuing or discontinuing of the antibiotic therapy. If the patient is having allergy, you can give clindamycin, of course. Nowadays, I believe that this clindamycin is not been given. It is substituted by clarithromycin, but I found it in Carranza. That is why I mentioned here. It could be azithromycin or clarithromycin. In acute or very severe conditions, you have to add, okay, metronidazole along with amoxicillin. So amoxicillin 500 mg, metronidazole 250 mg, or in case of very severe acute pain, you can of course give augmentin, which is amoxicillin plus clavulanic acid. Okay. So this is the incision and this is the drainage of the periodontal abscess through the periodontal pocket. Okay, the first thing is you anesthetize the area, and then this is how you see the probe here. It is slightly used to retract the gingival sulcus so that the abscess is oozed out to initiate the drainage of the abscess from the pocket entrance. You apply digital pressure here and then you allow the drainage of the abscess through this opening, okay, through the gingival sulcus or the entrance of the periodontal pocket. Now, if you see that it is not possible for you to drain the abscess through the periodontal pocket or orifice of the gingival sulcus, then of course you need to give a vertical incision right over the abscess. You just give a vertical incision right over the abscess. Or in this figure, they have done flap surgery. They have reflected the flap and then they have done a thorough scaling and root planing. Here they have drained the abscess and of course they have sutured. This is the surgical phase of management of periodontal abscesses. Now finally we have acute pericoronal abscess, which is very, very painful. As I told you earlier, the pericoronal abscess occurs due to the presence of bacteria below here. This is the operculum. Okay, if there is accumulation of bacteria between the operculum and the crown, then this is called as pericoronal abscesses. Generally, it is given there. It is also drained by digital pressure. Okay, you slightly lift the operculum, curate it nicely, give irrigation, make sure that there are no debris remaining, it is easily accessible. If you find out it is very difficult, then of course you can go in for the excision of this operculum. Okay. If the patient has systemic involvement, then of course antibiotics becomes a must. They should be prescribed. I hope you understood. It was a very short lecture on identification, classification, management of periodontal abscesses. Okay, you need to know the etiology, need to know how to differentiate between acute periodontal abscess, chronic periodontal abscesses. It's very important to know the management of it, in which circumstances you give systemic antibiotics, where it's okay for you not to give, um, how to initiate the drainage of the periodontal abscess, what are the clinical features of each abscesses I told you is important for you to know for this lecture. So I wish you luck for your final exam, and inshallah let's meet next year, that is the 6th year. So good luck.